I think that when you look at the data so far, we don't have a lot to actually guide us on that, right? We have the master trial with DARA-KRD, which used an MRD adapted design to de-escalate therapy. We actually at the University of Chicago have a study open right now called MRD to Stop, which I'm really passionate about. And what we're doing there is taking patients who have sustained MRD negativity while on maintenance therapy for at least a year and saying, look, your disease is under very good control. We actually can't even detect it. We think that you should be able to discontinue therapy. And then we are following people for 3 years after. There's also some important ongoing studies in this realm. So the dramatic study, which is a SWOG study, S1803, is looking at MRD-guided discontinuation of maintenance therapy as well. And I think these types of study designs are going to be supremely important. So I think we're going to see more and more clinical trials using MRD to guide therapy. There are ways that I am using it personally in the clinic right now, but I have to admit that is a little bit based on my own anecdotal experience and not as much on concrete data that we have available to us. But I think it's going to be supremely important to do two things when it comes to MRD guided therapy. The first is figuring out, how do we step off the gas? In other words, how do we de-escalate therapy for those who don't really need to be on therapy indefinitely, who may even be cured of their disease, which is a controversial thing to say in myeloma, but that might be possible. And the second thing is, how do we escalate therapy in a thoughtful way for patients who still have residual disease or have resurgence of disease even at low levels? In other words, maybe they convert from MRD negative to MRD positive. That's also a controversial area, but I think these are the things that we need to be focusing on as a research community to ultimately bridge those into the clinic.